Thanks, Diane. I'm Francesca. Today I'll be taking on the perspective of a clinical psychologist in a multidisciplinary approach to reducing the psychological effects of domestic violence against women. I'll be looking at the etiology and risk factors associated with domestic violence and exploring the various evidence-based practices that a clinical psychologist might implement to reduce the effects on mental health in women exposed to domestic violence. Given cultural shifts largely due to feminist movements such as second wave feminism, the relevant research and literature regarding domestic violence against women is reduced to the last 3 decades at a stretch. The issue at hand is largely an issue of inequality, as the statistics reflect that women are by and large the victims of domestic violence. That is not to say other groups are not exposed to domestic violence, but in this presentation we'll be focusing on women as the victim. In light of feminist movements, what could be seen as perhaps a matriarchal approach is perceiving the multidisciplinary approach as a circle. If we look at collaboration as a circle, each practitioner is placed around the circumference of the circle, making it stronger. This includes a position being held by the client, who, let's face it, will always be the ultimate expert of their lived experience. The multidisciplinary approach is in domestic violence is recognised by common risk assessment factors. So just to reiterate, domestic violence is violence and or abuse in a domestic setting, usually between intimate partners. So what is a clinical psychologist? Clinical psychologists are concerned with the assessment, diagnosis and treatment of psychological problems and mental illness. Clinical psychologists use scientifically established, evidence-based approaches. We've heard from an organisational psychologist and a counselling psychologist. So what can a clinical psychologist bring to the table in a domestic violence case? So this depends highly on the diagnosis of the individual, as all cases are different, but the main focus for me as a clinical psychologist is on the psychological factors associated with domestic violence and the evidence-based practices I can deliver to the client. There are a number of ways that a victim of domestic violence could be referred to a clinical psychologist. In Victoria, there are a number of government-funded services and organisations. The government only endorses evidence-based practices, so these services are reliable. In the case of our multidisciplinary team, I have been engaged by a counselling psychologist who will be an invaluable resource in my assessment and treatment of the client. So in looking at the etiology, origins and risk factors of domestic violence, I would flag that whilst it might be overly simple to name the abuser or the abuse as the etiology of any symptomology presenting in the victim of domestic violence, I would be very cautious not to use any language or direction that could align with victim blaming, or anything that puts any of the responsibility on the victim. So let me be very clear that domestic violence can happen to anyone, and most people exposed to domestic violence are at serious risk of short and long-term mental illness as a direct result of the abuse. However, there are risk factors that predict victimhood in domestic violence, including low self-esteem. And it is important that risk factors are first and foremost investigating the abuser, not the abused. Assessment approach and diagnosis. In every step of the assessment phase, I would be diligent in maintaining respect in the exploration of my client's personal experience and believing everything that they say is paramount, as is building trust and empowering the client, which could be achieved by recognising that they are the expert and making sure that they're aware of this. I would be closely collaborating with the counselling psychologist in order to deliver treatment that complements that of the counselling psychologist. And I would be looking out for evidence-based factors of risk assessment and again, consulting the counselling psychologist on this. I'm looking for a variety of symptoms that are specifically relevant to victims of domestic violence and relevant to what a clinical psychologist might be specifically concerned with. For example, feelings of helplessness, which is associated with depression, could be a key symptom I would focus on as a clinical psychologist. Helplessness is a common feeling in victims of domestic violence, and it could be a key symptom in the perpetuation of the abuse relationship, i.e., for example, a contributing factor in staying with an abusive partner. There are high prevalence ratings of trauma and anxiety in victims of domestic violence. I would be looking out for these as they might be causing other symptoms such as insomnia and hypervigilance. I'm also looking for the psychological underpinnings of the client's decision to stay or leave. Often in cases of domestic violence, we see victims experiencing difficulty to make decisions, which further justifies the need to empower the client, and we'll get to that in the treatment phase. Treatment and plan. Consulting other practitioners to understand their treatment plan and what they have performed already will inform the delivery of my treatment of my client. Throughout the literature regarding therapeutic techniques that can be delivered to victims of domestic violence by clinical psychologists, there is a focus on cognitive behavioural therapy and acceptance and commitment therapy. Specifically, the type of CBT used might be trauma-informed to specifically address the trauma associated with abuse. I would also be encouraging my client at this stage to report injuries sustained in the domestic violence to their GP, so it is documented for future legal reasons. I might deliver ACT with ACT, working with a client who is no longer experiencing domestic violence. I would also be concerned with creating healthy outlook on future relationships so that the survivor can live a fulfilled and empowered life. And this therapy could also be used with someone currently experiencing domestic violence. I would also consider cognitive analytical theory as an alternative therapy and one that does not come up in the literature. The reality of seeing a clinical psychologist is costly. With a mental health care plan, the client has limited sessions to see a clinical psychologist, even with legislation put in place to mitigate this. In this case, I would be looking at implementing CAT as a way to, 1, empower the client and build trust, and 2, this is a time-limited therapy. For future research, I would look into CAT as an effective therapy for victims of domestic violence, and also looking at education programs that are concerned with recognising an abuser in a relationship as an early intervention. I'll now pass you over to our education and developmental psychologist, Erin, to discuss the negative effect of domestic violence against women can have on children. Thank you, Erin.